Welcome back to the Deep Dive. This Deep Dive is powered by Book Podcaster, your shortcut to the most important information from the sources you need to know.
And we are so glad you're here, especially because for now, this is our final deep dive in our pediatric health segment. It's been quite a run.
It really has, and we wanted to wrap up with something, well, absolutely fundamental when you're caring for kids, something you see every single day.
Yeah. Pediatric skin conditions and care.
Right. And if you're feeling maybe a little overwhelmed by this topic, maybe studying for an exam, prepping for clinicals, or just, dealing with little humans with weird spots and bumps, think of us as your study buddies, here to break it down.
Exactly. The skin is the body's largest organ, right? And in kids, it's got its own quirks, vulnerabilities. Really important to understand.
So our mission today is to take the detailed material you shared excerpts on everything from skin anatomy, assessment, common conditions, injuries, all that stuff, and just pull out the essentials.
Yeah, we're going to cut through the noise, connect some dots, and hopefully make this whole area feel, well, a lot more manageable.
Let's just dive in.
Let's do it. Okay, foundation first.
Mm.
The skin itself. It's not just a covering, it does a ton of critical jobs.
Right, like temperature regulation being that first line of defense,
Yeah.
that barrier,
Yeah.
preventing vital fluid loss.
Eating vitamin D, yeah. Helping get rid of some toxins.
In touch, of course.
Exactly. And the layers, we know those. Epidermis on top, dermis underneath, and then the subcutaneous tissue deeper down.
But here's where it gets really interesting for kids. Their skin isn't just like a tiny adult version, right?
Exactly. Yeah, in newborns, infants, it's thinner, weaker. That's key, Makes them more vulnerable to irritation, injury, even absorbing things through their skin. Then as they get older, the skin matures. It gets more like an adult's more hair, more gland activity, thicker texture. That difference really shapes how we approach pediatric skin care.
Okay, so recognizing that babies aren't just tiny adults, skin-wise, is step one. Once we know that, how do we actually assess what's going on? The sources mentioned two main parts.
Right. First, you need a good history, asking all the right questions.
Like what?
Well, the child's general health. When did the skin thing start? Has it changed? Is it itchy? Big one.
And details like recent shots or meds, allergies, been sick lately. Anyone else in the family have something similar? Stuff like that.
Exactly. All that paints the picture. Then second is the physical exam, actually looking at the skin and how things are spread out. The pattern is super revealing.
Like, is it in the skin folds, the flexural surfaces, or the outside bits, extensor surfaces, grouped together, clustered, or kind of everywhere, scattered?
Spot on. And the sources get really specific, like you said. Is it following a nerve path, dermatomal, or a straight line, linear?
Or wavy, serpiginous, ring-shaped, annular, lacy, reticulated. It's amazing how those patterns point you towards causes.
Precisely. And also paying attention to which layers seem involved. Can you still see the normal skin lines on top? But there's a lump underneath, probably deeper, in the dermis.
But if the surface itself is bumpy or scaly or has little fluid spots,
then the epidermis is likely the main issue. And color, obviously, is huge.
critical.
And knowing the difference between primary lesions, the ones that start right on the skin, like a macule, that flat spot, or a vesicle, the little fluid bump, versus secondary lesions, those come later, maybe from scratching or healing, like crusts, or scars, secondary.
So we're looking, what's one sign the sources really flag? Like, red alert, can't miss it.
Purpura. Definitely purpura. It's this purple or blue spot on the skin that, and this is key, does not blanch. It doesn't turn white when you press it.
Okay, it doesn't blanch.
And the source material calls it an ominous symptom. That word. You got to pay attention.
Ominous. Yeah, that sounds like a big deal.
It really is. Purpura can signal critical stuff. Life-threatening things like bacterial meningitis or serious blood issues like thrombocytopenia.
So the takeaway is,
If you see purpura on a child, immediately tell a provider. No hesitation. Immediate notification.
got it, immediate notification for purpura. Okay, thinking about assessment more broadly, cultural competence comes up too, especially with darker skin tones. How does that change things?
Well, it's important because signs like pallor, paleness, or cyanosis, that bluish tint from low oxygen, or jaundice, the yellowing, they can be much harder to spot on deeply pigmented skin.
Right. So what do?
You look where the skin's thinner or less pigmented naturally.
Like where?
Inside the lower eyelids, the palpebral conjunctivae, and inside the mouth, the oral mucosa. For jaundice specifically, you also check the whites of the eyes, the sclera. Those spots give you a better clue.
That's a really practical tip. Okay, let's switch gears a bit. Hospitalized kids, the sources say they're at high risk for skin breakdown. Why is that?
Well, often they're sick, right? Acutely or chronically. That compromises their health overall, including skin. Plus, they're usually not moving much, and they've got all sorts of medical gear attached.
Ah, the equipment. Yeah, that
Yeah.
seems like a big factor.
Oh, absolutely. Yeah. Think about like surgical incisions. They need care. IV catheters. Got to watch for infiltration, where the fluid leaks out.
And all that tape for tubes and probes, pulse oximeters, nasal cannulas, urinary catheters. Tape seems harmless, but it's a real threat, isn't it? Both the pressure and when you take it off.
Totally. Removing tape can literally pull off the top layer of skin, the epithelium. Ouch. Then you've got ostomies, tracts, G-tubes, colostomies. Those sites are vulnerable from constant moisture, secretions.
Yeah.
Irritates the skin.
And really any equipment rubbing or pressing for a while. ETT tubes, traction, IV boards, casts, splints, even just cables. It all creates risk for pressure injuries.
And we don't just guess the risk, we assess it formally, often with something like the Braden Q scale for kids over 1 year old.
The Braden Q,
Right.
the sources list the 7 factors it looks at.
Yep. Mobility, activity level, sensory perception like can they feel discomfort and move, moisture, friction or shear risk, nutrition status, and oxygenation and perfusion. Tissue perfusion, it's pretty comprehensive. Helps flag kids needing extra watching.
So identifying risk with Braden Q is step 1. What about the actual nursing care? What do the sources say helps maintain skin integrity in the hospital?
It's really a bunch of proactive things. Frequent diaper changes, linen changes keep moisture down.
Yeah.
Using barrier creams like zinc oxide, especially in the diaper area.
Oh, and the sources mentioned you don't have to scrub off all the old cream each time.
Right. Just gently clean the soiled bits. Less irritation that way. Use water-based moisturizers for dry skin. Stick to mild pH-balanced cleansers, no harsh scrubbing.
Special attention to ostomy sites. Keep them clean, dry. Maybe foam dressings up.
Yeah, they can manage drainage. And just supporting the kid overall, good oxygen, good nutrition, that helps skin resilience.
And for kids who can't move themselves, position changes are huge. Every 2 hours, minimum.
Yep. And little positioning tricks matter. Keep the head of the bed lowish, like 30 degrees max. Lower the bed before you turn them to reduce shear. Keep heels off the mattress, maybe a pillow under the calves.
Use those special mattresses, egg crates, air flotation things.
Exactly. And really watch the back of the head and ears, common spots for pressure injuries in immobile kids. You can use foam dressings on bony spots for protection.
And minimize tape. Look for alternatives like gauze wraps or self-adherent stuff. Use skin preps under tape if you have to use it. And take it off super gently.
Finally, just constantly checking all the equipment probes, tubes, IVs for any irritation, and changing pulse ox probes every, 2 to 6 hours to prevent pressure spots there. It's a lot of little things, but they add up.
It really shows how much detail matters in pediatric skincare, especially in the hospital. Okay, let's shift to specific skin conditions kids acquire. External factors or internal stuff affecting skin.
We touched on pressure injuries already, risk factors again. Mobility, critical illness, poor circulation, poor sensation, medical devices, basically kids who are sick and stuck.
And the staging, super important for describing them.
Right, based on criteria like the European Pressure Ulcer Advisory Panels. Stage 1 is that red spot that doesn't blanch, skin's intact. Stage 2, you lose some skin thickness, see the dermis. Stage 3, full thickness skin loss. Stage 4, full thickness tissue loss.
And the tricky ones. Unstageable, where you can't see the bottom because of dead tissue, and deep tissue injury, that persistent deep red or purple area.
And the number one intervention, prevention. Always prevention. Identify risk early, use all those strategies we just talked about.
But if an injury does happen,
Then it's regular assessment, pressure redistribution, pain management, preventing or treating infection dressings, antibiotics, maybe debridement if there's necrotic tissue.
the sources mention things like hyperbaric oxygen or negative pressure wound therapy.
Yeah, sometimes used, but need more studies specifically in kids. For home care, it's all about teaching caregivers how to watch the wound, when to call for help, like signs of infection, how to do dressings, keep it clean, and continue prevention if the child's still not mobile.
All right, let's tackle dermatitis. We've all seen it. The sources talk about 3 main kinds.
First up, diaper dermatitis. Probably the most common baby skin issue, right? Irritation from urine, stool enzymes in there. You see redness, maybe some scaling, usually right where the diaper sits, those convex surfaces.
But sometimes it's more than just irritation. It can turn into a yeast infection. How do you tell?
Yeah, candidiasis, yeast. Often looks like well-defined red patches. But the key sign, the thing to really look for, are those smaller red spots scattered outside the main rash. Satellite lesions? That screams yeast.
Satellite lesions, got it. So treatment, simple irritation gets.
Zinc oxide ointment creates a barrier. If it's yeast, you need an antifungal, like nystatin ointment. For really bad inflammation, maybe a short course of 1% hydrocortisone cream. And always watch for bacterial infection signs, pustules, pus, ulcers, more redness. And prevention, home care is huge here. Keep the area dry, change diapers often, clean gently, warm water. Mild soap only, if needed. Cetaphil, Dove, Basis, Neutrogena. Avoid harsh wipes or scrubbing.
Let it air out sometimes, like 15 minutes 4 times a day.
Perfect. Avoid plastic pants over diapers. Use those thick barrier creams, zinc oxide, A&D, Desitin.
And the sources had a big warning about something. Powder.
Yes. Big no-no. Baby powder, cornstarch. Skip it. Inhalation risk can actually feed microbes in a moist area, and it clumps up, causing pressure. Just don't use powder.
Good to know. Okay, next type, seborrheic dermatitis. We call it cradle cap a lot.
Right. Scaly, kind of greasy look. Common on baby scalps, but can show up in body folds, face, behind the ears, too.
And a key difference from other rashes,
Yeah.
it usually doesn't itch. Non-pruritic. That helps tell it apart from eczema.
Usually diagnosed just by looking. Cause is often unknown. Maybe yeast plays a role. For prevention, daily washing with a mild baby shampoo helps.
If there is cradle cap, the sources mentioned a home remedy.
Yeah, warm olive oil or baby oil. Let it sit 15 minutes to soften the scales, then shampoo and gently brush them off.
Okay.
Third main type, contact dermatitis. Happens when skin touches something problematic.
Two kinds, right? Irritant versus allergic.
Exactly. Irritant is from stuff like harsh soaps, chemicals, maybe too much moisture, causes redness, bumps, maybe blisters, burning, weeping. Allergic is an immune reaction, usually way itchier. Severe itching, plus redness, bumps, blisters, often in patterns like streaks where poison ivy brushed against the skin or patches under nickel jewelry.
Poison ivy, oak, sumac,
Yeah.
common culprits. If exposed, what's the first thing to do?
Wash thoroughly. Soap and water. Within 15 minutes if possible, get those resin oils off before they really bind to the skin, once the rash is there. Cool. Wet compresses help. Burrows solution is good. Over-the-counter, itch creams, calamine, stuff with permoxin, menthol, camphor, phenol. For mild inflammation and itch, a low-dose 1% hydrocortisone cream, thin layer.
But if it's really bad, or on the face.
Yeah, need to see a provider. Might need stronger topical or even oral steroids. Oatmeal baths like Aveeno can be soothing too.
The sources mentioned latex allergies too. Relevant for healthcare folks or kids in the hospital a lot.
Definitely, it can cause hand dermatitis. Using vinyl nitrile or other non-latex gloves is important.
And just to clarify about poison ivy rash, the rash isn't contagious, right?
Correct. You can't catch the rash from someone, but the oils, the resin, can spread. From clothes, pets, even smoke if the plants are burned. So wash everything. All right, moving to atopic dermatitis. Eczema. Chronic thing. Pretty complex.
Multifactorial, the sources said. Genetics, environment, allergies, irritants, skin barrier problems, immune system, all mixed together.
And the result? Dry, super itchy skin. Families with asthma, allergies, or eczema themselves are at higher risk. That atopic march.
Clinically, it's scaling. Intense itching. Patches can be red, bumpy, blistered, crusty, sometimes weepy, and the scratching, big risk for infection.
And where it shows up changes with age, right?
Yeah, babies often get it on extensor surfaces, face, scalp. Little kids, more in the bends of elbows and knees, wrists, neck, behind ears. Teens, often hands or skin creases.
Because the skin barrier is compromised, preventing infection is key. Avoid exposing kids with eczema to stuff like warts or herpes simplex.
Diagnostics might include cultures if you think it's infected. Home care.
Yeah.
Lots of advice there.
Loose cotton clothes are best. Avoid wool. Mild, fragrance-free detergents and softeners. Wash new clothes first.
And the most critical thing the sources stressed.
Moisturize. Like crazy. 3 times a day. Hydration is everything for eczema.
Absolutely. Emollients moisturizers like Eucerin, Cetaphil cream, Aquaphor, petroleum jelly are super effective. Apply them 2 to 3 times daily and right after bathing while skin is still damp. Pat dry, don't rub.
Bathe every other day. Warm water, not hot. Mild soaps again. Diluted bleach baths were mentioned.
Yeah, like half a cup of bleach in a quarter tub of water. Can help reduce skin bacteria, keep the environment cool, humidified. Identify triggers, prevent scratching. Antihistamines at night help keep nails short.
Topical steroids and immunomodulators are the main meds. Watch for infection signs.
Some complementary stuff mentioned vitamins, omega-3s maybe help quality of life, but stick to recommended doses.
There was that really interesting bit about diet and eczema, the LAAP trial.
Oh yeah, total shift in thinking. Early introduction of allergenic foods, like peanuts, starting around 4 or 6 months for high-risk babies, might actually prevent allergies. Up to 80% reduction for peanuts, potentially.
Huge change from the old advice to delay those foods. High-risk babies might need an allergist consult first, though.
For eczema meds, topical steroids and immunomodulators are the go-to.
Steroids first, thin layer, then moisturizer over top. You can use occlusion, plastic wrap, damp towel over steroids for 10 minutes to boost absorption, but never over immunomodulators like tacrolimus or pimecrolimus. Those are usually for kids over 2.
Steroids come in different strengths. Be careful with medium-high strength on thin skin, like the face or neck risk of thinning, bruising, acne. Thin coat, short duration, usually like 7 days.
Okay, next up, another super common one, especially for teens, acne.
Manageable, but can be really upsetting, cause scarring.
The basic lesion is a comedone, a plugged follicle. Mild acne is just open comedones, blackheads, and closed ones, whiteheads. No inflammation there. Severe acne happens when bacteria, P. acnes, gets involved, causing inflammation, pustules, cysts, potential scarring. Usually starts on the face, then maybe chest, back.
Key management points from the sources. Gentle skincare, avoid oily products, and importantly,
Diet doesn't cause acne. Let the kids eat pizza.
good news. So education points, don't touch the face, don't squeeze things. Avoid oil-based creams. Cosmetics, look for oil-free. Clean gently 2-3 times daily with mild soap or cleanser. No harsh stuff.
Keep hair clean, off the face. Treatments. Topical comedolitics like tretinoin for non-inflammatory. Topical antibiotics like benzoyl peroxide for mild inflammatory. Sometimes oral antibiotics for more significant inflammation.
Those comedolitic creams make skin sun-sensitive, right? So sunscreen is a must.
Definitely. And for females, combination birth control pills can actually help reduce acne lesions if other treatments aren't enough.
Okay, last acquired condition in this section. Melanoma. More common with age, but can happen in kids, teens. Rare before 15. Strong link to UV exposure, especially those bad sunburns.
Genetics play a role too. Light skin, red hair, light eyes, family history, lots of moles.
And the key thing for kids, it can look different. The ABCDE rule doesn't always fit. Pediatric melanoma might be red, pink, thick, raised, nodular. Could arise from an existing mole. Watch for any changing or unusual mole or lesion.
Prevention is everything. Sun safety. Childhood sunburns can double long-term risk. Protective clothing, hats, UV-blocking fabrics, sunscreen.
Avoid tanning beds. Stay out of peak sun, 10 a.m. to 4 p.m.
Diagnosis is by biopsy. Treatment is mainly surgery. Medical options are being studied. Caregiver education. Surgical site care, follow-up, and regular full-body skin checks, especially sun-exposed areas.
Okay, let's shift to bacterial infections. Usually happen when the skin barrier breaks, letting bacteria like staph or strep take over.
Like impetigo, classic bacterial infection. Vesicles that rupture leave that honey-colored crust. Super contagious, often around the nose and mouth.
Sources said it can be mistaken for cigarette burns. Gives you an idea of the look. Tends to start in irritated skin.
Contagious until 24 hours after starting antibiotics. Usually diagnosed clinically. Caused by Staph aureus or group A strep.
Hospital care. Contact isolation. Hand hygiene. Treatment is topical antibiotics for mild cases. Oral for more widespread.
Home care education. Meticulous hand hygiene for everyone. Trim kids' nails. Disinfect surfaces, toys. Wash clothes, linens daily if contaminated. Cover lesions loosely. Finish the entire antibiotic course. Call if it gets worse.
Then there's the tougher one. MRSA. Methicillin-resistant Staph aureus.
Right. Staph that's resistant to common antibiotics. Harder to treat. Spreads easily. Prevention is key.
Clinically, might start small, like an insect bite lookalike, often where skin's broken. Can become warm, swollen, red, tender, maybe purulent drainage. Often looks like a boil, hurdle, cluster of boils, carbuncle, or abscess. If it spreads, that's cellulitis.
Gotta culture any drainage. That identifies MRSA and tells you which antibiotics will work sensitivity testing. Outpatient treatment often involves incision and drainage, I&D of the abscess, culture covering the wound, and antibiotics. Hospital admission for severe infections or cellulitis. Contact isolation. Meticulous hand hygiene. Sterile technique for wound care.
Complications, if it spreads, can be serious: pneumonia, meningitis, bone infections.
Home care education. Keep wound cover, hand hygiene, 30 seconds, soap and water, before and after dressing changes. Disinfect surfaces. Finish all antibiotics. Call for signs of cellulitis, spreading redness, streaks, swelling, tenderness, fever.
Repeated infections might mean colonization. Provider might suggest nasal mupirocin or special baths.
Yeah, colonization carrying MRSA without active infection increases risk for surgical site infections or spreading it. Hand hygiene is paramount, infected or colonized.
And MRSA resistance, partly from antibiotic misuse,
Yeah.
right?
Yeah.
Using them for viruses, not finishing courses.
Exactly. Antibiotic stewardship is crucial. Nurses teach proper use. Specific antibiotics for MRSA in kids include vancomycin, linezolid, clindamycin. Oh, and liquid clindamycin tastes awful. Mix it with syrup.
Good tip. MRSA prevention reminders. Hand hygiene, 30 seconds. Avoid touching nose. Disinfect stuff. Don't share towels. Use dryer. Keep wounds covered. Use MRSA effective disinfectants.
Okay, another bacterial one, cellulitis, can follow a small skin break or even sinusitis or ear infections.
Caused by staph, MRSA, H. flu, group A strep.
Yeah.
GAS cellulitis carries that rare risk of spreading, like necrotizing fasciitis.
Local signs, redness, warmth, swelling, tenderness, maybe red streaks, lymphangitis. Systemic signs, fever, chills, feeling generally unwell.
Diagnostics. Culture drainage, blood cultures of systemic signs, CBC.
Nursing care, monitor vitals, watch the site closely for worsening, check perfusion in the limb, monitor hydration, check behavior LOC, apply warm, wet compresses, elevate the limb, contact isolation, hand hygiene, pain fever meds, fluids, oral or 5 antibiotics, quiet play, home care education, call if fever increases or local signs worsen, finish antibiotics, warm compresses if needed, hand hygiene, refer to MRSA instructions if that's the cause.
Whew. Bacterial infections done. Quick break. Let's talk viral infections now. Common viruses, close contact spread. Some self-limiting, some lifelong.
Like papillomavirus warts or verruca, caused by HPV. Different strains cause different warts. HPV-2 common in kids.
Usually harmless, maybe just look weird. Plantar warts on feet, hands, HPV-1. Common warts on hands, HPV-2, are rough, scaly bumps.
Nail biting increases risk for warts under nails.
They're mildly contagious, so hand hygiene after touching. Don't scratch or pick. Risk of infection, scarring. Don't share towels. Many go away on their own in 2-3 years.
Treatments if needed. Liquid nitrogen, cryosurgery, salicylic acid prep.
Next virus. Herpes simplex virus 1, HSV-1, cold sores, fever blisters. Super common.
Painful little blisters, usually lips, mouth, often pop up with illness, fever, stress, leak clear fluid, crust over, incubation 2 days to 2 weeks.
And highly contagious during outbreaks.
Yeah,
But can spread even without visible sores.
exactly. Oral to oral spread is common, like parents kissing baby's mouth. It's lifelong intermittent outbreaks. Contagious for at least a week after first infection, 3-4 days after recurrent ones, maybe longer viral shedding. Can cause fever, irritability, swollen lymph nodes initially.
Hospital care. Contact isolation. Gown, gloves, hand hygiene, sanitize surfaces, cool, bland liquids because the mouth is sore. Monitor hydration, might need IV fluids or TPN if severe. 5-ES cyclover for severe cases.
Home care. Hand hygiene. Don't share cups, utensils. Sanitize toys. Avoid touching sores. Prescription creams like Abreva or Denavir can help. Oral acyclovir for widespread recurrent infections.
Complementary comfort measures. Cool compresses, lip balm with sunblock, OTC numbing creams, soothing mouthwash, diphenhydramine in baking soda mix, swish and spit.
Okay, next category. Tinea. Fungal infections. Ringworm. Not a worm.
Caused by fungi called dermatophytes. Likes warm, moist places. Spreads via contact people, pets, shared items.
Presentation varies by site. Tinea corporis, body ringworm, classic circular patch, raised edges, central clearing, itchy. Tinea cupitis, scalp, circular patches, scaling, redness, hair loss, breakage. Tinea pedis, athlete's foot, feet, common in teens, scaly or blistery, itchy. Tinea cruis, jock itch, groin, common in teen boys, scaling patches, sharp border, very itchy.
Diagnosis. Wood's lamp sometimes helps. Some fungi flares green. KOH prep is more definitive scrape lesion mixed with KOH. Look for fungal hyphae under microscope.
Home care. Topical antifungals like miconazole twice daily for body, foot, groin. Wet compresses, Burrow solution for moist areas first. Don't share hats, combs, clothes, bedding. Cover lesions. For athlete's foot, air feet, change socks daily, alternate shoes. And for scalp ringworm, Tinea cupitis, that needs oral antifungal meds. Topicals don't work well enough on the scalp. Systemic treatment is required.
Like grisophulvin or terbinafine. And that fun fact about grisophulvin.
Give it with high-fat food. Ice cream, peanut butter, helps absorption. Given for 4-12 weeks. Can cause nausea, sun sensitivity. Use sunscreen. Needs monitoring. Approved for kids over 2.
Speaking of meds and needing quick info, remind our listeners to check out the Drug of the Week podcast on our channel if they need a deep dive on a specific medication.
Great suggestion. Okay, back to skin. Let's talk about issues from insects. Infestations.
Pediculosis cupitis head lice. Ugh, so common, especially in schools. Easily spread, getting harder to treat due to resistance.
Prompt treatment and education are key. Look for nits. Eggs. Tiny white yellow dots stuck firmly to hair shaft near the scalp. That's how you tell them from dandruff. Flakes off. Nits hatch in 7–10 days.
Adult louse is sesame seed-sized, feeds on scalp blood, dies within 48 hours off the scalp. Main symptom is tickling, intense itching, scratching, infection risk.
Spread by crawling. No flying, hopping.
Yeah.
Direct contact, sharing hats, combs, towels, bedding. Diagnosis is by careful inspection under bright light, maybe magnifying glass, fine comb.
Home care education. Use pediculicide shampoo like Permethronex. Follow instructions, carefully apply, leave 10 minutes. Rinse, repeat in 7–10 days. Use fine comb on wet hair for nits. Soak combs brushes in hot water plus pediculicide. Wash clothes bedding hot water, hot dry cycle, or dry clean. Vacuum. Seal non-washables in bag 2 weeks.
And super important safety point, do not spray pesticides in the house. Toxic.
Complementary methods like mayo or olive oil overnight are sometimes tried but not proven effective.
Also check for contraindications. Permethrin pyrethrin shampoos can trigger reactions in kids with asthma or ragweed allergies.
Next pest, scabies. Mite infestation, Sarcoptes scabii. Burrows under skin, causes intense itching, often worse at night.
Lives on humans, can survive on surfaces briefly. Common in crowded places, causes outbreaks. Rash, often in finger-toe webs, groin folds, might see tract lines, bumps, blisters, pustules. Where it appears varies with age. Under toes, head, neck, palms, soles. Older kids, skin folds, finger toes, wrists, elbows, armpits, waist, thighs, butt, abdomen.
Intense itching leads to scratching, skin breakdown, secondary bacterial infection risk. Need to watch for that.
Home care, wash clothes bedding, hot water, hot dry. Seal non-washables in bag 5 days. Apply scabicide cream, permethrin 5% usually, entire body, neck, down at bedtime. Leave 8–14 hours, wash off. Repeat in 7 days. OTC itch creams help. Treat all close contacts simultaneously, even without symptoms.
Okay, what about insect bites and stings? Bees, wasps, ants, spiders.
Oh.
Local reactions common: red, swollen, painful. The big worry is systemic allergic reactions.
Exactly. Can range from vomiting, headache, fainting, to hives, wheezing, anaphylaxis. Delayed reactions, hives, fever, joint pain can happen days later. Brown recluse bites are nasty, can start mild and blister, ulcerate, become necrotic. Systemic symptoms possible too.
Nursing care for stings. Emergency focus on anaphylaxis. Assess airway, stridor, wheezing, circulation, hypotension, tachycardia, LOC. Give epinephrine, plus oxygen, IV fluids, nebulized albuterol, IV steroids, antihistamines.
For kids with known severe allergies, caregivers must have an EpiPen and know how to use it.
Go over the steps.
Okay, gray cap off, fist grip, don't touch ends, black tip firmly into thigh, 90 degrees till click pop, hold 10–15 seconds, remove straight out, massage site. Dispose safely. Check expiration dates. Know the dose, EpiPen versus Junior. Always seek medical help after use or for any systemic reaction or spider bite.
Home care for simple bite stings.
Yeah.
Wash, ice, 8–12 dagers. Elevate. Remove stinger carefully. Tweezers, gripper, don't squeeze. Antihistamines for itch. Carry EpiPen if allergic. Medical alert bracelet. Remember, many spider bites might be staph MRSA. Check tetanus for spider bites.
Last insect-related one, Lyme disease from infected deer tick bite. Transmits as spirochete bacteria. Symptoms 3–32 days later. Classic sign. That bullseye rash. Erythema migrans. Large circle, central clearing. Other signs. Fever, headache, aches.
Later, serious stuff can happen. Arthritis, neurological issues, facial palsy, meningitis, heart problems.
Diagnostics, blood tests, ESR, WBC, antibodies, EIA, Western blot, lumbar puncture if neurosymptoms.
Neurosymptoms are serious. Hospitalized kids often get IV antibiotics like ceftriaxone.
Prevention is key. Avoid tall grass bushes. Light clothes, long sleeve spants, tuck pants and socks in woods, permethrin on clothes, DT on skin.
DEET safety recap.
Apply to your hands first, then child, not for infants 2 months. Avoid kids' hands, ismuth risk. Don't apply over broken skin, don't spray near food. 10% protects 2 agers, 30% 5 agers. Choose based on time outside. Apply once daily. No combo DEET sunscreen products. Wash skin clothes after.
Tick removal. Tweezers close to skin, pull straight up gently, no squeezing. Remove retained parts, watch for Lyme signs after bite. Antibiotics. Amoxicillin for younger kids, doxycycline 8 years, if Lyme diagnosed.
Okay, final big topic. Disorders related to injuries. Common cause of childhood issues. Skin wounds need good care.
Like lacerations, cuts, tears. Surgical or accidental, management depends on depth, size, location.
Assessment. Size, location, cause, foreign objects. Indoor, outdoor, when first aid, bleeding, neurovascular status in limbs, movement, color, warmth, cap refill, pulses, sensation.
Nursing interventions. Pressure for bleeding. Irrigate well, normal saline. Check tetanus status. Assess with closure, strips, sutures. Apply sterile dressing, antibiotic ointment, bacitracin, polysporin, over sutures. Tissue adhesives, medical glue. For clean, straight cuts, seals edges, acts as dressing. No ointment over glue.
High infection risk wounds, dirty, saliva, crushed tissue, 24 years old, often not sutured initially, left open.
Home care education. How to care for sutures. Sterile dressing ointment, 24-48 then Clendri. Or strips, leave till they fall off, keep Clendri. Tissue adhesive. Gentle bathing. Okay, no swimming, scrubbing, pulling, no ointments. Hand hygiene. Signs of infection, redness, tenderness, swelling, drainage, fever. Call provider. Suture removal timing, 7-14 days. Pain management is important too.
Sources also mention different hospital dressings: foam for padding absorption, transparent films for IVs incisions, hydrogels for soothing burn abrasions, hydrocolloids for healing, alginates for heavy drainage, antimicrobial.
And the wound healing stages. Inflammation, cleanup, proliferative rebuilding, maturation, remodeling, strengthening.
Next injury type: bites, animal, human, punctures, lacerations, crush injuries.
Cat bites, deep punctures, hard to clean, highest infection risk. Big dogs, crushed here.
Infection signs within hours: redness, pain, swelling, pus. Hand-foot bites, high risk. Pasteurella common in dog-cat mouths. Rabies risk from wild animals, unvaccinated pets. Can damage muscles, tendons, nerves, vessels.
Immediate care. Irrigate aggressively. Large amounts sterile saline. High-risk bites. Hands, deep puncture, 8 years old. Often left open, not sutured. No tissue adhesives for bites. Traps bacteria. Check tetanus. Dress with antibiotic ointment, sterile dressing. Give antibiotics. Provide emotional support. Bites are scary.
Home care: watch for infection signs, cellulitis. Hand hygiene, wound care instructions. Importance of tetanus status, finishing antibiotics. Prevention: pet rabies vaccines. Teach kids kindness to animals. Don't tease, bother pets. Supervise young kids with pets. Leash dogs. Avoid strays. Discourage child biting. Rabies post-exposure prophylaxis info is also key if needed.
Sunburns next. From UV exposure, redness to blistering peeling.
Totally preventable. Daily sunscreen is critical for long-term health, reducing skin cancer risk. Even one bad childhood sunburn doubles risk.
Remember UVA, aging, UVB, burning, cancer. SPF protects against UVB. Use SPF 30 plus sun.
Prevention: avoid peak sun, 10 to 4. Hats, shirts, UV clothing. Sunscreen SPF 30 plus 30 minutes before exposure. Reapply every hour after swimming, sweating. Water, snow reflect UV. Infants 6 mo out of direct sun. 6 mo indirect sun, okay. Darker skin needs protection too.
Home care. Cool bath compresses, extra fluids, moisturizers, local anesthetic spray screens, acetaminophen ibuprofen for pain. Nurses should assess sun-exposed kids for unusual moles too.
And finally, the really complex one: minor and major burns. Heat, flame, chemical, electrical. Cause tissue death, coagulative necrosis. Degree matters.
Thermal burns most common. Chemical electrical can be deceptively deep, cause systemic effects, hypovolemia, edema, organ issues. Electrical burns risk cardiac dysrhythmias up to 72 hours later. Prevention education is vital.
Burn degrees: superficial first, about red, painful, no blisters. Superficial partial thickness, second, equals red, painful, blisters, moist, blanches. Deep partial thickness, second, dry, whited, maybe blisters, less pain, feels pressure. Full thickness, third, no blanching, no pain, white chart. Electrical, small entry exit, deep internal damage.
Assessing size using BSA charts, like Rule of Nines adapted for kids, is key. Minor 10% BSA, first, second. Major 30% BSA, or involves face, hands, feet, perineum, joints.
Hospitalization criteria: 10% BSA, full thickness 2% BSA, electrical, chemical, smoke inhalation, CO poisoning, suspected abuse, critical area burns.
Airway risk is huge with smoke, fire, chemical exposure. Can worsen over 24-48 hours. High-risk signs: face, neck burns, singed facial hair, soot, nose, mouth. Watch for cough, wheeze, dyspnea. Assume CO poisoning if severe confined space, minus 100% humidified O2.
Diagnostics: ABGs, carboxyhemoglobin, EKG, cardiac monitor, wound cultures, various labs, CBC, electrolytes, etc.
Emergency care. Airway first. 100% O2 if needed. Pulse ox. Assist intubation if needed. Cardiac monitor. 4V access fluid, central line maybe. Remove burn-taut chemical clothing. Cool sterile saline compresses NOICE. Monitor temp. Hypothermia risk. Tetanus check. Pain meds. Emotional support.
Acute hospital care: monitor respiratory status closely. Oxygen support. Elevate HOB. Monitor neuro-LOC. Watch for infection. Maintain IVs. Monitor INO. Foley, maybe. Neurovascular checks hourly on burned limbs. Report changes ASAP. Monitor urine for myoglobinuria. Frequent pain assessment meds. Espera before dressing changes. Sterile technique for wound care. Special dressings. Possible feeding tube. Maintain temp 37-38.5 C. Watch for hypothermia during dressing changes.
Chronic hospital care. Team approach, child life, OT, PT, social work, nutrition, debridement, manual whirlpool, escharotomy, skin grafting for full thickness, dressing changes, monitor hypertrophic scarring, silicone pressure, monitor contractures, pressure splinting surgery.
Chronic home care. Post-healing, still monitor scarring contractures. Huge emotional impact counseling therapy often needed for PTSD, anxiety, guilt, depression, child and family.
Sources noted PTSD is common, worse initially, but good pain management support helps long-term. Body image issues can persist. Nurse role includes emotional support, referrals.
Home care education continues. High protein diet, moisturize healed skin, cocoa butter, eucerin, etc. Manage itching, antihistamines, cool baths, diligent sunscreen SPF 30 plus on healed skin, reinforce burn prevention.
Key first aid again. NO butter, oils, ice. Cool water, superficial. Antibiotic ointment low. Partial thickness, cool water. Don't break blisters. Antibiotic ointment, nonstick dressing, watch infection. Check tetanus. Chemical, flush with lots of water, call Poison Control MD. Electrical, immediate medical help.
Also, consider non-accidental injury if story doesn't fit burn pattern severity. Report concerns.
Burn prevention education is huge. Chemical, electrical, thermal awareness, smoke detectors, fire extinguisher, infant safety, scalding, hot objects, sunburn. No holding baby while cooking, hot objects out of reach. Check car seat buckles, fire retardant clothes, outlet covers, lock matches chemicals, pot handles inward, supervise near heat, fireplace guards, check bathwater temp, set water heater 120F, fire safety for kids, safe outdoor play, prevent sunburn.
Sources noted higher burn risk in lower income countries due to different hazards, lack of safety devices.
Oh, okay. That was a journey. From tiny infant skin to complex burn care.
We really did cover a lot. Basics of pediatric skin assessment, urgent signs like purpura.
Risks in the hospital, preventing breakdown, common conditions like dermatitis, eczema, acne, even melanoma signs.
Bacterial and viral infections, lice and scabies, bites and stings, including EpiPens, and injuries like cuts and burns. Whew!
If you're working through this stuff, maybe for school or clinicals, hopefully this deep dive helped pull out the key takeaways from your sources, made it feel a bit more connected.
Yeah, understanding all this isn't just memorizing facts. It's about seeing how a child's skin really reflects their overall health.
It really does. Think about how something that looks simple, like a diaper rash or redness under tape, can sometimes hint at bigger issues. Or how just being vigilant with basic care prevents major problems.
What does it tell us about how connected everything is in the body
Mhm.
and how vital early detection and just thoughtful care really are for kids?
It tells us that every time you assess skin, change a dressing, teach a family about prevention,
Hmm.
you're doing incredibly important work. It's complex, yes, a lot to know, but you're building that knowledge to be there for kids when they need it.
You absolutely are. Keep learning, keep practicing, ask questions, use your resources, and, be kind to yourself along the way. It's tough, but you've got this. You really are making progress.
We've really enjoyed this whole pediatric segment, and thank you for joining us for this final deep dive in the series.
Thank you for listening. We really hope this was helpful for you.